The thing that I always say to clients, and this is said with so much genuine compassion, is that you're already living this. You've been living this for however long. So doing this therapy is not going to be as long as what you've been doing already. Doing this therapy, you will start to see that it has a positive impact, and it's not always going to be as hard or difficult as it is going to be at the beginning of treatment.
Hello and welcome. We're so glad you're tuning into the Taking Good Care show. I'm Dr. Andrew Wong, based in Toronto, Canada.
And I'm Dr. David St. Arno, based in Edmonton, Canada. We're two practicing psychologists with over a decade of experience each, working in a variety of settings and supporting diverse populations.
Thanks for joining us. We hope you enjoyed today's episode. While we're both practicing psychologists, our podcast is intended purely for educational and entertainment purposes. It's not a substitute for professional mental health care or treatment. If you're in need of support, we strongly encourage you to reach out to a licensed mental health professional in your area. Good morning, everyone. We are here, and Dave and I are both smiling. We are very excited to have a guest on today. And our guest is a friend of ours, Dr. Janice Dicks. And just personally speaking, Janice and I will never forget doing co-therapy with Janice back in our PhD days. And co-therapy, for those who don't know, is when you have two therapists in a room and we sort of feed off each other. We're sort of looking at the same people in front of us, and we're trying to help the couples or the families. And we're just sort of drawing on each other's knowledge and energy to try and help these people. But it was always so much fun. We would look at each other sometimes, see if we're on the same wavelength. And oftentimes we were. But it was also really nice because then I had somebody to debrief with after, somebody who you can sort of just let go of those emotions, whether it was laughter, whether it was exasperation, to be able to do that. So some of my most fondest memories with Janice. And Janice Dicks, Dr. Janice Dicks, is a registered psychologist in Edmonton, Alberta, and the co-owner of YEG Psychology. Her research from undergrad through her PhD focused on interpersonal violence and trauma, which set the stage for her professional work specializing in trauma. These days, she works closely with first responders, for example, police, fire, EMS, corrections, and military, as well as supporting mothers who've experienced birth trauma. And Dr. Dicks primarily works with adults. Janice is passionate about evidence-based practice to provide the highest standard of care, and she supervises the next generation of psychologists to do the same. Outside of the office, she's a married mom of two young daughters, and when she's not helping clients process trauma, she's busy chauffeuring, snack providing, and bedtime negotiating. Everything that we know too much about. So, welcome, Dr. Janice Dicks.
Thank you so much for the introduction, Andrew. I also think very fondly about those early days in our PhD. And don't forget those times when we would look at each other and maybe, because these were early days, think like, oh, I don't know what to do here. Do you know what to do here? And kind of give that like eye contact. And so having that backup in the room was always so good. You're right. I'm essentially a professional chauffeur these days and child negotiator. And to be honest, I think that will make an excellent future podcast for you guys. So keep me in mind for that one, please.
We will.
It's so nice to see your faces. And as I was preparing for this podcast, I couldn't help but think like it was this time 16 years ago, I think, that we were starting our PhD programs together, and a lot's changed since then, but love that you guys are doing this and love that you guys are providing this platform for us to get together and share our loves of the counseling and assessment field. So thanks for having me.
Yeah, I'm super stoked. Yeah, I've been looking forward to this podcast. It's been on my, calendar for a while. I'm like, we are going to reconnect. We always talk about connecting and it's hard to do that. So part of me is just happy to see your face and to be able to talk to you about some of the great work that you're doing and hear more about your work and a little bit of here and there, like what's going on in your world, because we also do that here on this podcast. So we get to share with the world kind of what we do personally and professionally, and mostly professionally. But yeah, so I've been waiting for a trauma focused episode for so long. I do some of this work too. I know that a lot of the general public, the people, the listeners are looking forward to this episode. Like it is a very mainstream kind of
Mhm.
popular topic now, but also with things being mainstream, there's a lot of misinformation too. So I'm hoping we can kind of sort through some of this and help the listeners better understand this topic.
I was going to ask Janice, I know with this particular episode, our focus is going to be on trauma.
Mhm.
And we always ask our guests because everybody has such an expertise in what they talk about. And we're always very interested in knowing how you got into this interest in working in trauma.
For sure. It's a long-standing interest. So I can think back to being in high school. So we're talking like the 1990s, late 1990s, and already knowing what I wanted to do for a career, but really wanting to be able to volunteer wherever a young girl could volunteer. I grew up in Corner Brook, Newfoundland, so that really sets the stage for my early volunteer experience. And I got really involved in women's organizations. So, wanting to help women that were in need. So, in small town Newfoundland, I started volunteering at a women's organization, a women's center, and also a transition house, which is a shelter for women who experienced intimate partner violence. And it wasn't surprising through that experience that in my undergraduate degree at Memorial University of Newfoundland, my research focus was on dating violence. And then, not too long after, at the University of Western Ontario, where I did my master's, and I believe both of you were there at some points in your academic career as well, I branched out a little bit and looked at how women who experienced intimate partner violence, how that may have impacted their experience in getting child custody within the court process. And then in my PhD, following kind of along the same path, I took a little bit more of a clinical spin and looked at how adult female survivors of sexual assault experience self-compassion. So it had a little bit more relevance in terms of the counseling room. And with that, I was able to continue on in terms of bringing that self-compassion piece into my work with clients, even still to this day. Now, that's the academic research side, which I have to say, and I had to put it in there because I think it really set the foundation for my clinical work. So, shortly after finishing my PhD, I had the opportunity to work in a rehabilitation organization where I was able to develop a specialty in workplace trauma. I had so many amazing, brilliant mentors during that time and received so much supervision that I always have to credit it back to those folks in laying that strong clinical foundation for the treatment of trauma. So that's where I started working with first responders. And then now that I'm a mom, I don't know if you guys noticed, but your clients generally follow you in terms of your life stages. So when I was in my early 20s, I had a lot of university students. These days, as a mom of young kids, I have a lot of, moms that are like in their 30s, 40s that are coming to see me. So now I've branched into working with moms who may have experienced birth trauma, for example. So it's kind of come with me throughout my life. And at YEG Psychology, it's mostly trauma work in terms of first responders and moms.
Well, thanks, Janice. I appreciate you kind of walking us through a bit of like where you come from on this topic. And I'm really curious in terms of like, how do you explain trauma to your clients? Or, you know, some might be coming to you with already knowing they've experienced trauma, but even, the term is quite vague and overused,
Mhm.
I think, a lot. So can you walk us through that a little bit?
Okay, absolutely. Are you prepared for a bit of a lengthy explanation here? And the reason why I say lengthy is that I think it's going to be really helpful for me to take you through how I explain this to my clients. Okay, so I'm not the type of psychologist who's going to use a lot of jargon. I explain things in very simple, plain terms that anybody can understand. So hopefully, this will help convey to your audience my perspective as a psychologist on trauma and also give, if there's therapists listening, some sort of language to use with their own clients, potentially to borrow. So you're right. I think it's really important to define what a trauma is from the perspective of a psychologist. Now, at its very core, a trauma is an event. It is one event, it is a series of events, multiple events, but it is events that overwhelm a person's ability to cope. The other key part about that is that what determines whether or not an event is going to be experienced as a traumatic experience is not necessarily the event itself. It's actually how much control the person feels that they have when they're in that experience. I'm going to just give an example here. So imagine you have two firefighters. They're both in a building that's burning. The roof collapses. Both firefighters get trapped. They're in different parts of the building. Okay. Roof falls down, collapses. Same experience on the surface. Firefighter number one. They know that their colleagues are nearby. Help is close. They've got access to their radio. People know where they are. They are pretty confident in their ability to get out. Firefighter number two, roof collapses. They're in a different part of the building. Radio, they can't find it. It became detached. They're not sure that anybody knows where they are. They can't extricate themselves from the rubble that they're in. They don't know if someone's going to find them. Who do you think is more likely to develop post-traumatic stress disorder from that event? This is a quiz.
I'll go with firefighter number two.
I was going to say the same thing.
Firefighter number two, absolutely. Because they felt trapped. They didn't feel that they had any control over the situation, right? Even something as simple as radioing can be a sense of control, right? And so essentially, this sense of helplessness and this lack or this perception of control and lack of control is often what turns a difficult experience into a traumatic one. Now, here's why, and you're probably going to hear me say the word interesting a lot because as psychologists, we find this stuff so interesting when we get at like the underpinning of what's really going on in the mechanisms of something like trauma. Essentially, when something overwhelming happens to us and we feel as though it's life-threatening, threatening to our integrity, things like that, what happens is our brain goes into survival mode. We are designed to look for threats, readily respond to threats, and you've all heard of that fight, flight, or freeze response. So when we're in an overwhelming situation, the brain is actually focused on survival and getting us out of that situation. It's not focused on properly encoding a memory. So what happens is when we're in that situation, stress hormones flood our body, right? The nervous system goes on high alert, and the memory isn't getting filed away into the past like it normally would. In normal memories, so for example, you both have young kids, I'm sure you've hosted some birthday parties, and I bet whoever had the last birthday party could tell me probably who attended, or most people who attended. You could probably tell me the venue. You could probably tell me what kind of cake you guys ate at the birthday party. It has a very defined beginning, middle, end. And when you talk about it, it's in the past. That is not the way a memory that's considered traumatic actually gets stored. Instead, in those moments, everything's dumped into the brain and body in a very chaotic fashion. It's not organized. It's not filed appropriately in the past. And what happens then is when it is so fragmented and disorganized, it's going to pop out. It's going to come out in intrusive experiences, images, flashbacks, nightmares, startle responses when you see triggers. So it's really a disorganization of memory of that at that point. And so when you say, or you hear of other psychologists, maybe you've heard of trauma being referred to as a disorder of memory by some folks. That's actually what's going on. It's not getting properly stored into long-term memory, neatly filed with a beginning, middle, and end. Instead, it's thrown in there in this very rushed fashion. And then because it's not appropriately processed, it falls out, and that's our trauma. Right. Now, I'm going to give you guys a couple of examples that I share with clients to illustrate this. So I don't know what the wildlife situation is like in Ontario, Andrew, but Dave, have you encountered some deer around here at all with your vehicle? Have either of you encountered deer before?
Absolutely.
Not hitting one, no.
Not hitting one. Dave, have you hit a deer?
Oh, geez.
Not sure.
Wasn't there an
Yeah,
owl
yeah,
story
I
a long
have.
time ago? You hit an owl, didn't you? Was that you?
I've hit an owl. I've hit some things. Yeah, yeah.
Okay. We're going to pretend it's a deer. And let me tell you, this deer survives, okay? So this is not a catastrophic event for the deer. The deer is okay. So I want you to imagine that you're driving on the Anthony Henday, and a deer dashes out in front of your vehicle. It realizes you're there a little bit too late, turns around, goes to run back into the woods, but you actually clip its hind leg. You just strike it with its hind leg. Our deer is probably going to do what?
Fall in the ditch.
He might fall in the ditch. His leg is okay though, Dave.
Okay, okay.
He's running into the woods, okay? He's getting off the road. He's probably in the ditch, actually. That's a good point. He's in the ditch. He's getting off the road and he is going to lay there. He has nothing to do, this deer. He is going to lay there. He's going to take care of his leg. He's going to do whatever he needs to do to feel okay. Doesn't have any appointments, right? Nowhere to be, no commitments. He's just going to take whatever time he needs to recover. And then when he's recovered, he's probably going to get up and walk that same road again, and he's going to be fine. Now, next question. You can decide who's going to answer this. Imagine you're in a car accident, okay? You've rear-ended someone, so you're at fault. And it's a pretty big accident. What do you do? What's the first thing you're going to do?
You check if everyone's okay. You check if you're okay. Just quickly look at yourself, see if there's any pain.
Yeah.
See if you can get out of the vehicle.
Mm-hmm.
Maybe
Couple of swear words.
Yeah.
Couple of swears. Gonna look for your license, your registration, your insurance. Might call
Yeah.
911.
Yeah.
Right. This is all assuming you can even get yourself out of the vehicle.
Right.
And then it's 4 o'clock in the day, and oh no, kids have to be picked up. Right. So you're making some phone calls because you're going to be late. And then I don't know how it works in Ontario, but Andrew, we have accident reporting stations here in Edmonton. Yep. So we got to get all of that figured out, deal with EMS, deal with police. There's a lot of things, right?
Yep.
There's a lot of things. You have no time in that moment to be the deer. You have absolutely no time to sit in your vehicle, take some deep breaths. Be like, wow, what actually just happened here? Oh gosh, that felt really awful. How do I feel right now? You have no time for any of that. In fact, you might not even have time to even think about this until 9 p.m. that night after the kids are in bed, and maybe you have a chance to talk with your partner about it. Everything about that accident is dumped into your brain in a really rushed fashion and has the potential to become a traumatic event. Okay? Another analogy I use, I promise this is the last analogy that I use with clients, is I always like you guys have like a cupboard or let's talk about the freezer in your fridge. Let's talk about like the fridge with the freezer on top. Okay. You can picture what I'm talking about.
Hmm.
You're rushing getting home from the grocery store. You're putting all your freezer foods in before you have to go get the kids from daycare or school. You don't organize it. Freezer is full. You're throwing it in there. What happens the next time you open the door? Food falls out.
Yeah.
Okay? That's trauma. That's how I explain trauma to our
Huh.
clients.
I'm gonna steal some of those.
Okay? They're pretty good, aren't they?
So I'm guessing your job is unpacking that freezer a little bit.
It's exactly what trauma treatment is.
Like as Dave said, it's unpacking that freezer. Is it, I'm gonna add a piece to that, is unpacking it in a way that's controlled. That like the way I see it now is like it's like Tetris. Right? So you're gonna unpack it and perhaps make sense of what's happening in the freezer, but perhaps also repacking the freezer in a Tetris-like manner where it's like we're gonna bring some control to this freezer here so that not everything falls out next time.
That's exactly it. Exactly. That's exactly what I explain with clients. And I'll say, oh, that was a steak, a frozen steak that we just looked at, and now we're putting that back in. Right? That's our bag of peas. Now we know what that is, and we're putting that back in. So it's a very controlled process, the way that we look at trauma. And there's a lot of different ways that people approach trauma treatment, which I think is really important to acknowledge that probably every school or theoretical orientation or way of practicing in the psychology field probably has interventions specific to trauma. But I want to say that they just because every therapist has their own way of working with trauma or every school has like their own interventions doesn't necessarily mean that they're the right interventions for your client or doesn't necessarily mean that they're going to be the most effective interventions. So that's a really important piece when we're talking about trauma treatment as well.
Yeah, I think we've echoed that many times on this podcast, right? That there's many right ways to do therapy and to do even trauma treatment. So
Mhm.
finding the approach that works best for you and, hopefully after today you have a bit of a better idea, maybe even what you're looking for if you're going to approach a therapist or a psychologist or a mental health person to get support with past events that have been, as Janice has described, like
Mhm.
falling out or showing up in ways where you don't expect them to, or even just, yeah, trauma triggers. I know we mentioned this before, but, you know, having something activated by something that
Yeah.
happens in the present, right? And that's how
Mhm.
a lot of times people can even go through traumatic events and not be bothered by them for years until
Mhm.
something similar happens. And then all of a sudden, yeah. So,
Janice, I have a question when you work with clients. Like trauma work, I understand can take a long time. It's a process. And as you were talking about sort of unpacking everything like that in and of itself probably takes time too. How do you go about informing a client? Because in my experience, so many people come to the office and they just want results, right? They want
Mhm.
to be quote unquote fixed. But because this can be a lengthy process, what's sort of your approach to explaining to clients, this may take a long time,
Mhm.
and this idea of the subjective experience, that they're experiencing, because sometimes they also come and say, well, someone else has been in a similar scenario and they're not experiencing this. Why
Mhm.
me and why is it going to take so long?
I think like the first piece is it really depends on the type of trauma.
Mm,
And I think that that can, as a therapist, as a psychologist, that can give me a good indication of what we're in for in terms of treatment. So if we're talking about long-standing child abuse, right, that really affects someone's developmental years, then I'm going to think that like pulling that apart, processing, sorting through all of that with a client is going to be quite the process. If we're talking about a single incident trauma, so for example, an EMS worker who had a very traumatic experience with a patient, or we're talking about a birth trauma that had ultimately positive results in that the baby was safe, healthy, everybody survived, and it was okay, it wasn't complex, then I'm talking to my clients and that, we could probably do this in not a whole lot of time, like usually about 10 sessions, to be honest, based on the evidence-based treatments that I use. If we're talking about multiple incidents in adulthood, for example, say we have a first responder and we know that they have like cumulative trauma. So their traumas are usually not just one, they have them stacked on top of the others. And the cool thing about the treatments that I am trained in is that it has a generalization effect. So they could be like, oh my gosh, I'm going to be here for years. No, you won't. We're going to go in and we're going to sort through the most difficult one. And the way that we do that is going to have a generalization effect on the others. So you're going to feel better about one, the most difficult. We're probably going to go to the second most difficult. And then we probably don't even need to touch the third, fourth, fifth, sixth, or seventh because your symptoms have already settled. And what you learn from me, you're going to be able to generalize it to everything. So the time frame is very variable. But the thing that I always say to clients too, and this is said with so much genuine compassion, is that you're already living this. You've been living this for however long. So doing this therapy is not going to be as long as what you've been doing already. Doing this therapy, you will start to see that it has a positive impact, and it's not always going to be as hard or difficult as it is going to be at the beginning of treatment.
I like that. I think, with trauma, like you were talking about earlier, it's quite disorganizing, it's quite destabilizing, and listening to you talk and explain it in that way, it can create a sense of comfort that there's a plan, that there's a process. It doesn't mean that it's going to get better right away, but that, if we kind of go through it in this systematic way that you've been trained, generally people will cope better, feel better, have a relationship with their past experiences better.
Yeah. And it sounds like it's already bringing that sense of control that the therapy itself is going to provide if you can, as a therapist, give that structure of how this may play out in a world, an experienced world where things are so disorganized, the thoughts are chaotic, they're running a mile a minute. Being able to work with somebody who says, we're going to slow all of this down, we're going to take a systematic approach to it, that's already bringing some control. Sounds like that way anyway.
It's a really great point, and I think that's exactly what's happening. And this is why I talk about when I'm training provisional psychologists or supervising them, I want them to go get the training, like the specialized training. I don't want them necessarily just doing supportive counseling. I want them to know how to treat trauma in the most effective way possible because it's really important. When someone's coming in for trauma treatment, they are scared. Nobody wants to do this. Nobody wants to go through and open up all the things that their brain is essentially telling them, do not do this. This, thinking about this, feeling this, encountering reminders of this is dangerous. They do not, your brain does not want you to do this. So you're essentially at war with yourself to some degree when you step into the therapist's office. And I have to be the one to convey confidence and competence. And by me saying, I got this, I got you, here's what we're going to do. I got a plan. I know exactly how we're going to do this. That is what helps the client feel hope. And that's what helps them engage in treatment. And one of the things I always say to clients, and if you were to like make a circle with your hand, so I've got my two hands here and I'm making kind of like a ball, as though it's like almost like I'm holding an inflated balloon. This is life before trauma. When trauma happens, it wants you to stay away from reminders of the events. And what that can look like is that you start avoiding a lot of things. And your life then gets more and more and more narrow. And for those of you who can't see me, my hands are no longer as though they're holding a ball, but they're coming and they're getting very, very, very narrow. And that is the trauma survivor's life when they come into therapy. And I tell them that I'm going to make their life full again, as full as I possibly can. Might not be that huge fullness that they felt prior to the trauma, but I'm going to get them as close back to what they were before as I possibly can. And that conveys so much hope that it's motivating for them to come back and to give this a shot.
Just out of curiosity, will you ever tell a client, because again, working with adults, sometimes it's like, okay, they want to go back to the way it was, but then it's like, is that possible to go back to the way it was? And so this idea of like, can it be even better or different in a positive way rather than let's go back to what it was like in the previous chapter?
Mm-hmm. Trauma treatment, it's difficult.
Yes.
A mentor of mine in that rehabilitation facility that I mentioned, Dr. Lori Rossi, a brilliant, brilliant trauma therapist, she would say to clients, it's like Buckley's, the medicine?
Yeah.
It tastes awful, but it works. And we can take you through the trauma treatment. And it's depending on the approach or depending on the client, they could be like, oh gosh, Janice, I don't know if I could do this again, but they keep showing up because they have faith in the process. And I have had many clients say, like, do you think we could get a lobotomy instead here? Is there something that we could do to erase our memory, to, just take this out? And I always say, oh boy, I wish we could take this away from you. The problem we have is that your brain is actually never going to forget it. We're never going to go back to life before the traumatic event. It's impossible because your brain did what it needed to do and it captured every single bit of that information that it felt like it needed to keep you safe. And so moving forward, it's not going to be surprising. And I prepare my clients for this, for triggers to come. What I can do is help you to be in control of the trauma, be in control of the thoughts and the emotions and how much they bothered you, rather than the trauma controlling you. So I tell them that, like, nope, we can't go back there. But one of the beautiful things that's emerging in research, and I remember touching on this in my PhD, is this concept of post-traumatic growth. And that is like life actually can be better. It can be fuller. People become more self-aware. Some people have increased spirituality, spiritual connections, positive psychology. That's a very familiar approach to me in working with clients, right? We can learn to laugh about things. We can learn to see the hope. People will give back. They want to help. How many first responders have I treated? And then they go on to run like peer support programs and things like that. So life can be better post-trauma, but it's not going to be the same as it was before. You are different now. Things have changed. We're going to help you integrate that experience.
Yeah, I want to even just go back a little bit. I want to pick up on something you said about supportive counseling versus trauma treatment. And I think this is super important. I think, correct me if I'm wrong, but a lot of supportive counseling, we're going to help people feel better and not really kind of go into the areas that are uncomfortable a lot of ways. We're like creating comfort, validating and reassuring people. But with trauma, at least with the training that I've done, like you're saying, you actually need to go to the hard parts. And so sometimes the questions are like, what was the worst part of that event for you? And that's counterintuitive to a lot of the, supportive, caring people out there. It's like, oh no, don't ask about it because that'll make them feel distressed or upset but it's actually what needs to happen to be able to integrate and heal and move forward with that experience in their life. So I just thought it was super important to highlight for, people listening and practitioners out there. So I don't, yeah.
I think that's a really important point. And I think that is the difference between someone who has specialized training in trauma and maybe someone who has learned about trauma but doesn't have that extra additional training in those evidence-based practices that we use. Trauma is a hot topic among therapists, right? Everybody that goes to graduate school wants to learn and specialize in trauma. And to go into a counseling session with someone who is experiencing trauma and to just go in with that person-centered approach where we are empathizing, validating, normalizing, that is lovely. But trauma kind of wants you to do that. And I say that because trauma doesn't want you to get in there. Remember, the brain thinks it's protecting the individual by telling it to stay away from thinking, feeling, doing. Avoidance is actually a key component and a symptom that we need to see if we're going to diagnose someone with post-traumatic stress disorder. So whenever we have those re-experiencing symptoms like images, thoughts, feelings, flashbacks, nightmares, the brain says, whoa, 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 these are dangerous. Distract yourself. Don't think about this. Let's avoid behaviorally, cognitively, emotionally. And then it gives the person some relief. And then the cycle continues again. Effective trauma treatment is going to say, sorry, trauma. It's not so much working for the person to avoid thinking, feeling, doing. Instead, as a therapist, I want you to be thinking, I want you to be feeling, I want you to be doing. Because when I get you to do that, you actually are teaching your brain that you're safe. You can think about it, you can feel about it, and you can do things. And you learn that you're not in that trauma anymore. That was in the past. You can do all of these things now. And then the intrusive images settle down, the nightmares settle down, your life starts to become that full circle again, bit by bit, because you do more and more and more. A therapist who's going in and is afraid to ask those hard questions because the client is scared to go there is not necessarily doing the client any service. So even if a client is afraid, there's ways that I can titrate the treatment. Even though I use protocoled approaches to treatment, and the myth maybe is that, oh, they're too rigid. No, they're not. As a clinician, I get to decide. I can do bits and pieces. I don't have to do the whole thing if it means my client isn't going to be in their window of tolerance. So there's so many things that when we're trained, we can do and adjust to make that treatment fit for the client so that it's more tolerable for them.
Yeah. Janice, you touched on, being able to settle down the nightmares, being able to settle down, let's say, the dissociations or any kind of anxiety coming across the traumatic event, the trigger. And I want to go to that word trigger because many of us who live our lives and let's say it's a motor vehicle accident and, we don't plan to be in a motor vehicle accident, right? Or we don't plan to be put into traumatic situations on a particular day or a particular week. And then it happens, right? And now, after the fact, the person is feeling all these different unwanted, symptoms, side effects, whatever you want to call it, of that particular event, right? And so now let's say they avoid the intersection where it happened, or they avoid driving altogether. So in terms of being able to, let's say, go back to that intersection or being able to drive in or being able to go back to a job where, if you're a firefighter or a police officer, to go back to all of that, to be functional again, how do you help that person face that particular fear that their body and their brain is telling them to avoid, avoid, avoid?
So when we look at triggers, and I just want to say triggers are essentially reminders. That's a synonym for triggers. It is a reminder of the trauma. Remember that the reminders serve a purpose, right? Because the brain says, oh, this isn't safe, danger, 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 stay away. When I have a client come to me shortly after a motor vehicle for accident, for example, or shortly after a work-related incident, we usually have a period, a window that we hope for a natural recovery where we don't need any major intervention. It's not until like about 30 days post incident that we're going to see a diagnosis of PTSD come in, right? We're kind of in the acute stress disorder phase, and there's a lot that we can do with that. So, for example, when someone's coming to me shortly after a motor vehicle accident, I'm asking them about what they're avoiding, but I'm also going to be encouraging them to get back in the car. I want them to get driving. I want them to drive past the accident site if they're able to. So I'm going to get in there and I'm going to be promoting all of that, trying to figure out all the things that they're avoiding. And I'm going to try to get in there with early intervention. Now, if someone's coming to me later or it's way more ingrained, the best treatment that I think for a situation like you described, Andrew, is treatment called prolonged exposure therapy. It is one of those evidence-based treatments, and it essentially addresses the avoidance head on that's related to trauma. There is an imaginal component to that treatment where I get them to retell step by step in very vivid, extreme detail what happened. And we actually record that. And then they are to listen to it daily if possible for homework. What that does is it settles down the feelings, the thoughts associated with it internally. So it almost has like a desensitizing quality to it. We re-record that next week and the week after and the week after, and we take measurements of their subjective feelings of distress, right? And as that starts to settle, we notice that their thoughts and feelings start to settle. At the same time that we're doing that, we're doing what's called in vivo exposure. That is real life exposure. Now, a therapist that's working in isolation, a psychologist that's working in isolation is going to be planning this with the client. They're going to be doing what we call a fear hierarchy. They're going to be rating how distressing it is to sit in a vehicle, to ride as a passenger, to be at an intersection, to be where the accident actually took place. Right-hand turns, left-hand turns, whatever the triggers are. And they're going to be assigning the client homework to approach those within their window of tolerance. And we usually talk about a good window of tolerance between 4 and 6 out of 10, where 0 is not afraid at all. 10 is, I'm so scared, I can't do this. Okay. So 4 is like, we're a little bit anxious, nervous, not too much that we can't still think and rationalize our way through. The cool thing about our practice at YEG Psychology is that we have occupational therapists who are mental health trained and exclusively do in vivo exposure therapy. So at our practice, when we've encountered a client who has trauma and they need some of that extra help with avoidance, we pair them with the OT. We're doing the imaginal in session as the psychologist. The OT is out there in real time, getting in the car with the client, even if they have to hire a driving instructor or a driving school to help facilitate that. And they are teaching them regulation strategies, so grounding strategies. They're helping them to enter into the vehicle at like a 1, 2, or 3 out of 10, rather than an 8, 9, or 10 out of 10, where they've got some wiggle room, rather than being so heightened when they get in that it's not going to be a positive experience. So they are taking them out and giving them that in the moment support. And I cannot say enough about that psychologist and occupational therapist team that we have at our practice. It leads to the best outcomes when we've got these two clinicians working together with the client.
I absolutely love that. Yeah, we do not have that at my clinic. So this might be on my list of things to do. Maybe I'll have to poach one of your OTs here and there.
Or you can, yes, exactly. You can refer over for OTs. They work so well with psychologists that they're fantastic.
Well, and I can tell that you've done the work with like workplace injury, right? Because this is commonly a team
Yeah.
approach, right? So if someone is injured at work, you would naturally have OT involved. You would have other, interdisciplinary team. So I love that you've brought that into your private practice. And yeah, I'm really taking note of that right now.
Oh, Janice, I mean, it really shows, you've done this work for so long and, there's so much you're sharing with us right now. In terms of that trauma piece, you had mentioned sort of a preamble to our conversation today, the big T and the little T.
Mm.
Could you talk more to that?
Yeah. Have you guys heard of that language referring to trauma as big T trauma and little t trauma?
I have. Probably not to the level of your knowledge, so go for it.
In the trauma world, and when you hear other therapists talk about trauma, they often refer to big T trauma and little t trauma. Now, when we talk about trauma, right, we're referring to an event. So our big T traumas, usually major, catastrophic, life-threatening. They are ones that, like, those are our physical, sexual assaults, natural disasters, stuck in a house fire, that type of stuff. As someone looking in would be like, oh my gosh, that must have been so traumatic. And then they talk about little t traumas. And those are defined as things that on the surface you might not necessarily recognize as traumatic, but they're emotionally wounding experiences, right? It could be a parent that criticizes you throughout your whole life, could be attachment wounds. It could be emotional neglect, relational betrayals, microaggressions. They're usually chronic, cumulative, and they're not necessarily recognized by others as necessarily being significant, but they have an impact on your safety and trust and just your overall well-being in the world. So you get into the therapy room and we're like, okay, well, this doesn't necessarily meet that life-threatening diagnostic criteria that we usually need for a diagnosis of PTSD. But gosh, this looks a lot like trauma. So it's kind of like if we were to use an analogy, our big T trauma is like a hurricane hitting your home all of a sudden, destructive, unmistakable. And then our little T trauma is like a slow leak on your roof that eventually, over time, weakens the structure and if can be significantly damaged if it's ignored. I will tell you, I don't like the language. I do not like the language. And especially when we're talking to clients about saying, that's a big T trauma. Oh, you have a little T trauma. For those clients who experience big T trauma, that's validating. Whoa, yeah, it felt big. It felt big. Thank you for saying that that's big T trauma and that I fall in that category. Those that experience little T trauma and you call it a little T trauma, that sounds really invalidating to me.
Mm.
Mhm.
And at the end of the day, no matter what theoretical orientation I'm working from or what trauma treatment I'm doing, I want my client to feel validated in my office. I want them to feel as though their experience was significant and it mattered. So when I cringe, I have this internal cringe when I hear
Mhm.
about the differentiation between big T and little t trauma. And I will not use that in the room with clients because a trauma is a trauma is a trauma. It's all big, it all matters.
I'm totally with you. I hate the language too. And just going back to your intro and your definition of trauma, right? Like it's not so much the event, it's how it was experienced by the individual. So focusing on that, but so much of just even the history of PTSD diagnosis, it was really reserved for specific events, right? And it was event focused. Now, with more and more research and more understanding, we're moving away from like, what the actual event was and how it impacted the individual. Did they feel
Mhm.
overwhelmed, out of control? Those are the pieces that are so important. So this language kind of distracts us a bit, right, from the personal experience of the individual. And so I really like that you've explained that excellently. So thanks.
Yeah. It makes me wonder the history of where that came from, right? Because in our field, like you said, it's so invalidating. And what I'm interpreting is that it doesn't necessarily take a rocket scientist to say, Oh man, that's invalidating, right? Like, but it does make me wonder historically where that big T little t came from and from what world like did they try to categorize it, right? Because to both your points, it's like a trauma is a trauma is a trauma. Your interpretation of it is significant, and that's all that matters.
That's what ultimately matters. Exactly.
Yeah, and I think like clinically, it actually stops people from getting help, right? They're like, this can't be trauma, it can't be PTSD because I wasn't, my life wasn't threatened, right?
Hmm.
So it's like, okay, where did where did you learn that only trauma came from those kinds of events, right? And so people might be struggling a lot on their own because they're not even recognizing the impact that something has had. So Janice mentioned something earlier about kind of living with it and having survived it. And one of the phrases that I love from, I think it's Bessel van der Kolk's Body Keeps the Score book, but basically reminding people it's like, that was then, this is now, right? So it
Hmm.
allows you to ground yourself in the present moment, but also remember or re-experience to some degree what happened in the past. And I think a lot of times when we're doing trauma work, that's what we're doing, that kind of dual consciousness. And so I thought you mentioned it, but I really wanted to highlight that because even for the general public, it can kind of get you out of a jam when you have a reminder or a trigger that happens to ground yourself that, like, oh, yeah, that was back then. I'm right here, right now. I might, you know, take a note of this and go to therapy and deal with it later. I actually don't need to re-experience this to this degree in this moment. I could maybe keep playing with my kids, or I could maybe keep doing my job right now. And I think that's another important piece about like trauma work is that we can actually learn to kind of contain some of it and still address it in really specific intentional ways. So I'm curious a bit about that for you, Janice, in terms of seeing that in your office.
In terms of seeing people contain or what that looks like.
Yeah, like helping individuals, know that the trauma just, if you go there, it doesn't need to spill out all over all the time.
So that is learned in treatment, right? So I can say that I don't, but I could say that to someone when they first come into treatment, but it doesn't make sense. It's not until we've gone through a course of that evidence-based treatment, whether we're doing cognitive processing therapy, EMDR, or prolonged exposure therapy, one of those, and once they start to realize that they have some control over those thoughts, feelings, reminders, only then does it make sense.
Mm.
So we can't necessarily say that from the beginning, but as we start progressing through treatment, we can show them that, hey, look, you just did that. You just managed that. And now you can go do this. This didn't just carry over and ruin your whole day. One of the things about these types of treatments that we do is that there are some strategies, right? We teach clients about grounding strategies. In EMDR, there's very specific visualizations that we have people do in terms of creating a container to put those things in. And they can visualize putting those things in the container so that they can shut the lid or however their container looks and come back and deal with it later, or imagining that calm space that they can go to. And that allows you to focus on that for a few minutes instead of what was bothering you. So there's lots of different strategies that we can use. One of the things that I always tell my clients as we're finishing up treatment, and I'm a little bit more of a direct therapist in my language, is, and I usually have like quite a good banter with my clients by the time we've been through this course of treatment. And they're usually saying, you're right, Janice, you were right. I wasn't buying into this in the beginning, but you're right, it worked. And I say to them, don't get complacent. Do not get complacent because you are going to have more triggers come up. And if you're not paying attention or you're not thinking that, oh, this can still impact me, you're going to be blindsided. But what I want you instead to keep in mind is I can encounter triggers and I can put them away. Maybe if they're sticky and they stick with me, I can make an appointment with Janice again and we'll sort through it. But for now, I can put it over here. It doesn't have to control my life. and I can get back to playing with my kids, for example. And when we've done the course of trauma treatment and I have a client come back and they're coming back and they're like, oh my gosh, my world is falling apart. I just encountered this trigger. I'm right back into the trauma symptoms. What's remarkable, it usually just takes one session and I've got them settled again because we know the principles of our treatment. We know the fear avoidance cycle. We know the grounding strategies. I essentially remind them all of everything we've learned. And I say, of course, you had that reaction. That's a trigger of your trauma. And at that point, the normalization and the validation works really, really, really well. And that's often all they need to settle down again so that they think they're not going crazy.
Yeah.
This is actually just a normal reaction to a trigger that you weren't anticipating.
So that's such an interesting point, Janice, because to not be complacent, but yet also make sure to enjoy what's ahead of you and be with your loved ones, connect with them, be playful, smile, be hopeful. And I'm guessing too that within the course of treatment and therapy, we're also learning to do that. So it's not like, okay, don't be complacent doesn't mean to, okay, live in a state of anxiety and be mindful of this, and this, and you have to be on the outlook for these things. But it's just being able to relax, be calm, enjoy, and yet still not be complacent about it.
Mm-hmm.
When I hear don't be complacent, I hear remember what you learned, right? And if they're coming
There you
back
go.
to you for the reminder, it's like, and for some people, like even the phrase like remember your training, right? It's like, oh yeah, I know what to do with this. I know how to handle this.
Yeah.
I've learned. So I don't want people to be like hyper vigilant and on guard all the time, right? This is about just like you've already done this. You already know. Yeah. So
But that's where treatment's so powerful, right? Like this is where you have to learn to become that way.
it's a
Exactly.
learning process.
Yeah.
Yeah.
And you're right, Andrew. The thing about treatment is I want you to do. Remember, when we go back to that like circle that got narrower and narrower and narrower, I'm not just focused on the trauma treatment in my work. I'm focused with making the world bigger and bigger and bigger again, getting it
Mm.
as full as I can. So when I have clients, for example, who are off work from trauma and they're afraid to maybe take a vacation, or maybe they're afraid to be seen out in public at a game or something like a hockey game because they should be homesick. And I'm like, no, 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 that's not how this works. I want you to do. I don't want you to hide. Trauma wants to keep you hidden. I want you out there and I want you practicing enjoying life again. So that's a really big component of our treatment. Once we start to get some of those strategies and start to get some of that processing underway, I want you out there and I want you living your life and I want to get it as full as I possibly can again.
So, Janice, Dave and I do this thing at the end of our episodes, sort of like what can we take away from what we talked about, what our guests informed us of. And so I'm going to ask Dave, today's episode, I mean, Janice gave us so much, is there sort of any takeaway message for you today?
Oh, it might be a little bit of a recency bias. I think just hearing Janice talk about this, like how trauma can shrink us down or kind of limit our experience of living, and how treatment or at least addressing trauma, past traumas, can help us expand and live more fully, richer lives. To me, I love that. I love that that is the product of actually doing something that's really not pleasant and really, most people would want to avoid. But knowing that on the other side of it is this fuller life, I love that.
And I think for me, it's the reminder that, there are no big or small traumas. The trauma is a trauma and it's subjective. It's experienced, right? What one person experiences and interprets, even if someone else experiences a similar or same thing, the interpretation may be different. And so if you believe that you have experienced trauma, it should be validated. And treatment is so important to have somebody who's experienced in treating trauma because there is a way to do it well. So Janice, thank you so much for being on our episode today. It was such a joy to catch up and to chat with you and see what's been going on, all the trauma work that you've been doing. And it's pretty cool because we see from our cohort, everyone's we're all in psychology, but we're all sort of working in different areas,
Mhm.
right? Whether it's couples, children, EFT, trauma, it's pretty neat to see how everyone's branched off. So, Janice, thank you again. And you can find Dr. Janice Dicks at yeg-psychology.com. They're also on Instagram, Facebook. Look them up. They're doing amazing work in Edmonton, Alberta. And if you've enjoyed this episode, please subscribe, follow, give us a thumbs up, leave us some comments. We love to hear from our listeners. And it really keeps us motivated to continue producing episodes because of some of the great feedback that we've received. So thank you again, Janice.
Thank you so much, guys.
Thanks, Janice. Take care.
Take good care.